Good afternoon, everyone. iTech India and the Center of Excellence, STM Hospital, Kolkata, welcomes all the participants for today's RDLS session. Today's topic is differentiated service delivery models, and the speaker is Dr. Nivedita Dutta. Dr. Nivedita Dutta is currently working as the Senior Medical Officer with COE STM Kolkata.
Hello. Yeah.
Yeah, ma'am. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Sweta, for that introduction. Today, my topic of discussion is differentiated delivery models. Basically, we are delivering a lot of services in our ART centers, but to cater to to basically optimize the available resources, we need to think about the differentiated models. Now, what exactly is my topic today? By the end of the session, we hope to understand about what is the differentiated service delivery model, the concept of patient-centric care, the types of models we have, examples on different types of the DSDM, that is differentiated service delivery model, and the interventions that we do. This is a part of the HIV prevention testing, that is our guideline. And in the guideline in chapter 4, we have this DSDM model, and it simply gives as a good idea of what I am talking about today. An approach that simplifies and adapts HIV services to better serve the needs of PLHIV, optimize the available resources in health systems. Approach can be applied to prevention, testing, and treatment, and has the potential to address multiple diseases, not just HIV. Basic rule is it's a public health program where we have lots of patients attending the ART clinics every day. So what we need to do is operationally, we need to optimize our resources. Whatever resource we have, it should be categorized like in emergency services. Whoever has done, we know that we have a triad system where we categorize patients according to the needs they have. Some might be having an emergency, some may be kept for waiting. So this is important in our services also, and also with most other healthcare services. This differentiated model has come up where we need to understand which patient needs what. Now, the differentiated service delivery is a person-centric approach to HIV prevention, testing, and treatment. It is like moving away from a one-size-fits-all model. DSD tailors HIV services to diverse groups of people living with HIV while maintaining the principles of the public health system. Now, as the picture is a very interesting one, it elaborates like we cannot cater to all our patients in the similar way. Some will need more specific attention, some may bypass the physician, and that is what I will be talking about. Now, basically the building blocks of the service delivery system. There are 4 main building blocks that are surrounding a client, and the building blocks are based on 4 basic questions. That is, when to deliver, where to deliver my service, who will deliver my service, and what to be delivered. Now, basically, we have to answer these 4 questions before assessing differentiated care. Like, what is the service we want to give my patient or client? That is very important. We have to remember that we are catering to a very diverse group of people who are coming to the ART centers. So if the group is diverse, my service will also be different. It will not be the same for all. Now the foundation of understanding is, when should that service be delivered? Is it a monthly service? Is it a bi-monthly service? Is it a quarterly service? Or is it a 6-monthly service? Where the service is being given, the basic question is it an HIV clinic or hospital, a primary health care system, other clinics, community, or home? And who will be delivering the services? Is it a physician? Is it the clinical officer, a nurse, a pharmacist, a community health worker, or client, peer, or family member? And now, what are the things that need to be delivered? That's also very important. Now, is it ART initiation? Is it ART refilling? Is it the clinical monitoring, adherence support, adherence counseling, laboratory test, opportunistic infection treatment, psychosocial support? So these are the four: when, where, who, and what are the four building blocks. Depending on these four answers, we will be able to decide, we will be able to understand from where the patient will be getting his best service. If it is a ART initiation patient who needs a physician, who has to come every month, who has to come to the HIV clinic, it's one type of a care. If it is a patient who is doing very well for the last few years, who is it doesn't need the not need to seek the physician at every visit, he only needs adherence, continuing of his medicine with good adherence, and he needs the laboratory tests. So this patient need not come every month, he can come once in a quarter. So this is what I was talking about, the foundation of understanding. This is basically what we need to understand as healthcare providers. Also, we need to understand few things, like we are giving a service where the service is basically patient-centric package. So it's not just that I want to deliver the medicine, I want to do a blood test for my patient. It's not enough to think like that. In the present scenario, it is more important to think with slight amount of empathy that what is the best approach to treat the patient. Best approach means we have to think about the patient centric, like in a patient centric manner. That is, we have to think about the intensity of the services, service frequency that he needs, the service location that is best for him or her, and the healthcare worker cadre, the cadre of person who is best to give him or provide the service. Now, with people living with HIV, as we all know, they have to collect medicine on a perennial system. Like they will be collecting medicine as long as they live. So here comes the importance of delivering the medicine to these people at a time which is convenient to them, at a place which is convenient to them, and by people who is the best or the easiest for them to approach. And what are the things that need to be done for that patient? Is it a clinical laboratory support? Is it a psychosocial service that they need? What is exactly the need of the patient? That is also very important for us to understand. And how often are the services to be provided? Like, is it a monthly or a bi-monthly, quarterly, or a 6-monthly service that is required? Where is the service best that should be provided to him? Need he come to the ART clinic or a primary care center or community or home-based services? And who will provide the service? These four things need to be understood with clarity for all patients. It's a task that can be done one time in one year. We need not do it at every visit for every patient. But what in the long run, with all the studies of adherence, like the poor adherence studies, whatever has come out from the LFU tracking and the missed patient, the reason for missing patient, for patients being missed, whatever has come out from these studies is a very basic question is, we are giving services, but are we giving the services to help the patients according to their schedule of life? Like, our services should not be hampering their jobs, should not be costing much to the patient. If a patient is traveling 200 kilometers to collect his medicine, if he is a patient who is stable, he can well off take that medicine from someone that is who is some peer or some NGO or some lab which is positioned close to his house. Now, this is a study model that was done a few years back. It's a DSD1 to DSD2 model. Basically, health services nowadays, we talk about like it should be a comprehensive health service. Like a patient is coming to my clinic, it doesn't mean that he will be picking up only the HIV antiretroviral drug. A patient, when, as we all know, our patients are doing quite well with the new group of drugs. So a patient is expected to have a better life expectancy. And with better life expectancy, patients will be having common diseases, the chronic ailments a normal person has with aging. So diabetes, hypertension, and the other infectious diseases. Apart from that, family planning needs, preconception, periconception counseling, all these things should be wrapped up in a single model. So this description of that was proposed in one study as the DSD1 model to that the DSD1 model was a HIV centric model, and the DSD2 model is an inclusive model where the chronic diseases like TB, family planning, non-communicable disease, and all others are taken together. And this taking together always helps us to understand and help the patient. It prevents the patient from running from one outdoor to the other. It helps him to have a comprehensive healthcare it is to provide a comprehensive healthcare to a patient. It's not that I will ask my patient to go to the diabetic clinic one day of the week. I will ask him to go to the normal general medicine one day of the week. Another day I will expect him to go to the chest clinic. So it's best that we give the comprehensive treatment, a package at the ART center level. Now, who should be offered the differentiated care? We have this in our national operational guidelines for ART services. As I have mentioned in the chapter 4, we have these packages for better retention. Now, the stages of loss to follow up. Who should be offered the differentiated care? This is a graph which gives us a very useful information. Most of us, we are already acquainted with this graph. We have seen this before. So this measures the leakage or loss. It's a graphically explain. It graphically explains which are the leakage sites, which are the loss sites where we usually lose our patients. First is the stage 1, that is a diagnosis of HIV, that is the ICTC to ART. That's the first loss we usually have, that linkage loss. And the second stage is the ART initiation or just the pre-ART, like when we are preparing a patient, the preparedness counseling were not enough to convince the patient to start his ART, or maybe after 1 or 2 doses, patients started having some side effects, they did not feel well, and the patient left the treatment. So these are the stage 2 illness, LFU stages, where we have the loss after enrollment. And the stage 3 is anytime during the course of the ART, a patient is lost. And this is basically because after some time, what happens is after a uh, initially we keep on counseling, initially we stress on the importance of ART, but after a few months and after a few years, when they feel well, usually patients start missing their pills, or they are busy with their jobs, they go out of station. So this is the time they start missing their dates, and some also unfortunately move into the stage of LFU. So this is the pipeline which is bringing a fluid into a tank, and there are sources where there are leakages. The water is, or the fluid is flowing away. And one of the saddest part is the death of the patients, where we know that that's one of the uh, causes of poor retention, where we have the death of the patient. So to retain our patients, what we need to do is we need to fill up the leakages at stage 1, that is at the enrollment from ICTC, stage 2, just after enrollment, and stage 3, that is during the course of ART. Now, one other important mechanism is the LFU tracking. By LFU tracking, what we do is we get back our patients. We try in all sorts of methods with the help of NGOs, with the help of house tracking, with the help of our peer counselors and all. We try to bring back the patient and we keep him in the retention pool. Now, the retention, the PLHIV are vulnerable for LFUs. We know most of the studies have shown that the patients are vulnerable to become LFU in the first 3 to 6 months of their HIV treatment. One major cause is the psychosocial factor. Usually, we keep counseling about the ART intake, about the timing of ART, about the blood tests that need to be done, the follow-up visits that need to be done. But what we forget is the stigma, the psychological issues that a patient undergoes when he is starting his ART. Every person is at the end of the day a social being. So his surroundings, how to cope up with his new ART uh, changes, how to cope up with his regular visits to the hospital, his missing of 1 day's wage, 1 day's absenteeism from his work, all these and the queries from his friends and his other colleagues and the neighbors. These are all issues that crop up into the minds of ART patients and which is basically overlooked by our counseling system. We just cater to his ART intake, the pill count, the body weight, the blood tests that need to be done. We have to be very, very much empathetic to our patients during the first 6 months of their antiretroviral treatment, because this is the time the patients have come to know that they have to go for a lifelong treatment. It's not easy to make one understand, make him or her it's not basically understanding, it's coping with the stress. So the patient has to cope with a lot of stress. He has to make himself understand that this is a new system. I have to go along with it throughout my life. The major causes of LFU include the side effects of ARV drugs and the gaps in preparedness counseling. That is what I'm talking about. It's a preparedness counseling. I have to I have to help my patient understand that these are the pills you have been given. You just need 1 minute time if it's a once daily dose or a 2 minute time in your 24-hour schedule. And these 2 minutes will help you live for another few decades. And that will be a smooth living. So these are the preparedness counselings we need to do. And apart from that, side effects of ARV drugs are a major cause, which we really can't help. We can counsel, we can ask him for visits, but these frequent visits are often a deterring factor for patients to be lost to follow up. Now, the framework of patient-centric differentiated care, as we know, it's a rapid ART and early case management, intensive follow-up and early tracking, tracing for missed appointments, differentiated care to decrease the barriers. So first we treat, then we go for early retention, and then there is the challenge of long-term retention. Now, patient-centric service across the treatment cascade. After we have enrolled a patient in HIV care, what our differentiated module tells us is we have to basically categorize our patients. And this categorization will be because we have a limited amount of healthcare services. Now, the limited amount of healthcare services will need some amount of optimization. What is optimization? We will be having patients who are doing well. We will be having patients who need more care. We will be having children who need utmost care. So, at the ART clinic, we have to understand which patient will need 1 minute, which patient needs 5 minutes, and who needs at least 10 to 15 minutes of my care. So this is the categorization WHO is also talking about, and it's a new model, new system where a triage is being done to help the caregivers and also help the patients who receive the care. So the package A, the first package is basically the initial 6 months. The initial 6 months for any new patient is the package A patient. It can be a patient who is a normal positive, seropositive patients with not much ailment. And it can also be a package A plus category patient who has an advanced HIV disease. We know that advanced HIV disease is WHO stage 3 or 4, a child aged less than 5 years, and a CD4 of less than 200. These three types of patients will be marked as package A plus. That is, they are small children. They are the patients who are having advanced HIV clinical infections or diseases, and those people with a poor CD4. They will be A plus. That is, they are in the first 6 months of their ART initiation, but they need a little more care. After 6 months of ART initiation, we will be doing a viral load testing for all our patients. And this real testing, it can have two outcomes. A patient may be virally suppressed, a patient may be unsuppressed. A virally suppressed patient is a stable patient. Now he or she moves into the package B. A virally unsuppressed patient is an unstable patient, and she or he moves into the package C. Now the package and the services we are giving. This is the left side, we have the package A and A plus, and on the right side, we have the package B and the package C. The basic criteria is package A and A plus, as I said, it's less than 6 months, and the package B and C is more than 6 months. Now, package A, as we all know, they went through preparedness counseling, address verifications, identification of caregiver. They were screened for TB and other OIs. They were rapidly initiated on ART. They were given TPT or the TB preventive treatment. They were given CPT if they were eligible as per the guidelines. They were give the case management intensive follow-up for 6 months has to be done for all of them. We may do tracking and tracing depending on the need. A viral load testing will be done at 6 months. Now, patient-centric packages, particularly for the patient key populations like adolescents, children, and pregnant women, we have to talk to them frequently. We have to give them special time, and we have to give them psychosocial support. The package A plus is advanced disease management, less than 6 months, but advanced disease like less than 200 cells per cubic millimeter of CD4, child 5 or less than 5, and a WHO clinical stage 3 or 4. These all need lots and lots of care. These group of A plus patients really need our care and support. And we have to give them enhanced adherence counseling at every visit, because continuing on ART with good adherence is very important for all of them. And the PLHIV on ART for more than 6 months, for these cases, we have to understand that the viral load testing has to be done at 6 months of age. After 6 months, if the patient is doing well, we will tag him as package B. When we tag him as package B, then this is a good patient of mine, as we say in common terms. So this patient is eligible for MMD or multi-month ART. He will not be asked to come every month, because we have already seen for the last 6 months that he is a good, he has shown good adherence and he has good understanding of the ART needs. And now for him, we can always co-locate that patient to the nearest TSDI site or the CSC. We can tag him with some CSCs, with some NGOs, with some linked ART centers, with any refill groups. And we will always just tell these patients, we can give them 2 or 3 months of medicine. What we will explain to them for the need for visits at their schedule, routine blood tests, and the viral load tests. The package C is the patient who needs specific enhanced adherence counseling, because as we know that after 6 months, these group of patients have not done well. We have to go for patient-centric packages, particularly for the key populations like adolescents, children, pregnant women, because as we know, for pregnant, we keep on doing the viral loads once in the first trimester, again after 30, in between 32 to 36 weeks. So these are patient-centric, that is a case-centric management, case-to-case basis. Now the case management will be focused on individualized care for the PLHIV. What we will do, we will ask them to go for reminders in their mobiles. We will go, plan for home visits, particularly for patients who are returning to care after being MIS or LFU. So what is important is here is basically with our package A patients, we are giving them 5 minutes to 10 minutes time. For a normal patient, package A is 5 minutes enough. We can give package A plus a 10 minutes time. But for package B patients, only a minute time is enough. He can just walk into the ART center, a body weight and basic question if he has any ailments is enough. And this person can well pick up his bill from the counselor and just go to the pharmacist directly. This package B patient need not seek the physician at every visit. In with the package C patient, he is an unsuppressed patient where we will avoid MMDs. This patient has to go for intensive adherence counseling or enhanced adherence counseling as we call it. Package C patient needs to visit the nursing staff, the doctor at every visit, because unsuppressed patients will pick up OIs and these need to be monitored very, very closely. And we also need to understand that the package, basically C patients are very prone to have other infections. So all other types of opportunistic infection treatment is important for them. So these are the unsuppressed patients. And in my last slide, as I said, the package A patients, they usually have a yellow sticker. The package B patients who are taking MMD will have a green sticker. It's almost like the traffic lights we have. It's a green sticker. And the package C usually has an orange sticker. These stickers, if they are pasted with the white cards, it's very easy for the ART center staff to understand at a glance that, oh, this patient of mine is a package B patient. I need not keep wasting time to keep asking him multiple questions, and he need not wait for a long time. So the patient is also happy, and the caregiver can optimize his services to the ones who need it more. Now the package A, preparedness counseling, address verification, these are the things we do at the initial initiation registration time. Identification of the caregiver, symptom screening for TB, rapid ART initiation, prophylaxis, TB prevention, treatment, CPT, case management, intensive follow-up with tracking and tracing. These are the things we need to do. Now, the case management intensive follow-up of 6 months with tracking and tracing, and the prophylaxis stage 3 or 4 illness, CD4 less than 200, and children 5 or less than 5. Now the A plus sticker, we will write A plus across the sticker, and for basically, if every 15 days for the first 3 months, we will be tracking by telephone, just a phone call to ask the patients, are you taking your medicines on time? Do you have any issues? These are the basic few questions that makes the patient or subject feel important, that, okay, my center is taking care of me. So if the patient is not turning up, then also we will telephone him. We will giving for CSC tracking, and we will also mention the poor adherence or the MIS and LFU in the white cards. Now, package B or C, as I said, package B is a basically green sticker and the C is a unsuppressed orange sticker that is given after the VL testing. Now, stable patients for adults, usually more than 10 years, we call it a stable patient if he's on ART for 6 months, if he's having no ART side effects, no OI, no current illnesses, virologically suppressed, CD4 is more than 200. Adherence is more than 95%. Children less than more than 2 years on ART for 6 months, suppressed viral load, treatment adherence more than 95%, on the same regimen for the last 3 months, and no OI, no current illness. Now, triaging of patients to package B or C, as we said, repeating the viral load doing the first viral load at the 6 month of age on ART, and then stable is a green sticker who is suppressed, and then unstable is the orange sticker. Now, after 6 months, a patient is on after 6 months, Mrs. X was tested for viral load. It was found to be TND. Which package of service will you provide her, and what services would be provided to her? So basically, as I said, once a viral load is being done, a patient moves from the package A to either package B or C. To decide on which of these two, we have to look at the viral load test. So if the viral load test is TND, that is target not detected, this patient shows suppressed viral load. So the package will be basically B. So the services that will be provided to him will be a MMD. He will not be asked to come to the ART center at every visit. If he finds it difficult to travel such a long distance, there may be peer groups who will be collecting the medicines for him. We have the community ART refill groups in Andhra Pradesh and other places already working. So the ART refill groups can pick up his medicine. He can be shifted to a nearby link ART center. He can collect MMDs up to for 3 months of schedule. And we will always try to do the blood test and everything at one visit, so that this package B patient of mine is not bothered by multiple visits to the ART center. Now, the package B who are stable should be considered for differentiated service delivery, like multi-month, as I said, link ART centers, community-based refills groups. For all patients on first-line ART, routine blood viral load testing should be done at 6 months and 12 months after ART initiation, and thereafter annually. For first-line patients, as we all know, after initiation, viral load has to be done at 6 months for all first-line, and then annually. For second-line patients and the third-line patients, viral load testing has to be done every 6 months. White card of the patients will be having a green sticker, that is package B has to be mentioned in that. Multi-month dispensation, as I said, is ideal for package B patients. But one thing we need to remember, that when I am giving my patient the opportunity to have multi-month dispensation, that is, he also has to comply with the treatment protocol. That is, he has to come on the specified date. Since he is coming only twice in 6 months, that is, he's been given medicine for 3 months at a go, then he should be honoring the date he has to come. So if a patient is missing his dates, we will not be giving him this MMD. So a call has to be made within 48 hours of the missed appointments. We will share the list with the CSC. Home visits may be planned by the end of that same week. And we have to label that patient as miss or LFU as per the guidelines. Now, the community ART refill groups, these groups have been like they were initially at a testing model, and these are now in operation in Andhra Pradesh. And this has been seen that the community ART refill groups, it's a proxy medicine pickup type thing, a self-forming group of stable PLHIV from the same geographical area, like adolescents only, or family units, or community group network of members, or of a specific key population. It is managed and facilitated by the PLHIV themselves. community members, peers, networks, CSC, CBO, ATI, and the other providers. These groups are formally registered at the ART centers along with details of focal person and all group members. So they have to register at ART center. We may be having 10 FSW who are doing very well on their ART. So each and every client does not need to come to the ART center for their refills. One person can take a note of all the people of the shared people for whom he or she is taking the medicine. But the person who is coming for the pill pickup should note the adherence of all the members of the car group. And he also should know that none of the members of the car group have any viral load or CD4 or any other test which is pending. That is also very important. And these groups should be formally registered at the ART centers because one person is being given medicine for the rest 10 also, rest 9 also. That is total 10. And that person should also have some understanding of the medicines which has to be given to whom. Usually these car groups have been operational with the most of the NGOs at Andhra Pradesh, and it has been seen that it's very good, and it has come to use because of the different people have in visiting the ART center at multiple times. So these are individualized approaches. We have to understand this is not for all, and this is not at all for unsuppressed patients. This is only for the stable PLHIV. These groups have been instituted, and these have they are in place. And we have seen that with stable patients, if the medicines can be delivered at their foot and at their doorsteps, this helps in keeping a good adherence with a few group of patients. Now, the CARG model: identification of a group by the ART counselor, identification of a focal person. One person by rotation collects the medicine. It's not that only one person is coming at every visit. If there is a group comprising of 10 members, one member comes at every visit for the rest 9. 4 symptoms have to be tested by that member before he is coming for all the group members, and he has to calculate all the remaining pills that are with the patient, with the his peer, and visit by each member at least once in 6 months, and follow-up mechanism by the ARTC. This is the basic standard operating procedure for the CARG model. The responsibilities of CARG members: the focal person has a responsibility of timely ART pill pickup and refill. He has to estimate, monitor the adherence and the forest symptoms for his peers. And if he feels that the person has any OI, any adverse effect, he or she needs any other care, like a woman having prenatal, antenatal care, she needs, then these members have to be brought in by the focal person. And the other members, their responsibility lies with maintaining good adherence to the pills, attend the group meetings, visit the ART center as per schedule, inform the focal person for any concern. Now, the package C, as I spoke about last, is the unstable patients, basically unsuppressed patients after 6 months of ART. We will keep counseling them, the enhanced adherence counseling, repeat the viral load tests after 3 months. As we know that we will counsel at every visit for 3 months. And after 3 months of good adherence counseling, good and ART intake, we will repeat the viral load at 3 months. And if the second viral load is also high, we will refer the patient to SASEP as per the guidelines. Now, this also has a individualized approach. Now, when a patient is unsuppressed, we will look into the spouse testing. We will again recheck whether her children has been tested or not. If it is a mother, we will again check for breastfeeding issues. We will check for the 18-month test of the infant. And we have to, because individualized approach is important, because I know this patient is failing. So there will be issues will be cropping up with people who are very close to the patient, that is his spouse, her child, and we need to give individualized care. Home visits are important by the ORWs, phone calls, checking the phone numbers, avoiding MMDs with this patient. But there's only one exception, though I am telling that avoid MMDs. There's an exception with truckers and migrants. If the reason for poor retention was a trucker unable to come every month, we can give him a second chance by dispensing ART for 3 months with enhanced counseling, and we can do a viral load testing at the end of 3 months. So what is being done here? In spite of the fact that the patient is failing on his regimen, if I can identify as a counselor or a physician that the main cause of being a failure is the inability to come on the pickup dates, specifically to come on the pickup dates, or that he has missed his ART few weeks before the viral load was done, only in these specific cases, we will give MMD to the patient, that is my trucker patient, and we will counsel him to come for his viral load testing at the end of 3 months. These cards will be tagged with an orange sticker and as package C patients. Now, management of PLHIV with unsuppressed viral load. So what we are doing is we are asking the patient to spouse test, as I said, partner testing, children to be tested, and enhanced adherence counseling, 3 sessions by same counselor. This is very important. And this same counselor, this thing has been identified that different counselors counseling at different sessions does not help the patient at all. And if not able to come to the ART center, telephonic counseling, visits by the ORW, home visits, these are all the other things. 3 months of good adherence, then repeat the viral load, SASEP referral if not suppressed, and switch as per SASEP recommendations. So monthly phone check-in by the counselor, SMS reminder. What these are the individualized approach, case to case basis approach, and the peer counseling support for disclosure, stigma, gender-based violence. As I said, all our patients are at the end of the day social beings. So it is not enough if we counsel him only about the ART, only about the pill. There are other issues which are affecting his retention in HIV care, like the gender-based violence, stigma, partner violence, depression, substance abuse, and these are the things which need our care and attention. Pale HIV who return to care after being missed or LFU should be provided a friendly and welcoming environment. And we have seen that these individualized approaches, almost they bring back 30% of our miss and LFU patients. Now, PLHIV with poor adherence to ART, they may, if the poor adherence is mainly due to the inability to make routine clinic visits, challenging such long distances, as I said, with the truckers. So as on a case-to-case basis, I can give them MMD and their adherence should be ensured. But if I'm linking them to the lags, we have to follow them up on a case-to-case basis. Now, coming to the DSDM, differentiated service delivery model categories, we have usually two broad classifications, that is the group model and the individual model. A group model is management by the healthcare worker or the management by the client themselves. Healthcare workers, like for all our patients, we especially the children, as we said, that they are the advanced disease patients, advanced management patients. So for them, we can have the welcome back clinics. For adolescents, we have the adolescent clubs where they can share their own problems. Managed by the clients is the community ART refill groups, the community client-led ART deliveries, and the individual models. Usually they are the orphanages, the LACs, the FSW population. These are based at the facilities. And the fixed community points like the churches, the mobile outreach bike intervention, which has been tried at Nagaland, and the home delivery systems. So the individual models are catering to individual patients, and the group models, either by the community or by the healthcare, is catering to the group of people. Now, examples on different DSDM interventions, we have this Mitwa, an initiative with Mumbai DAX for the adolescent living with HIV. Decentralized, most of the decentralized things have been done in the states where the prevalence was shooting up, like in Andhra Pradesh and in Nagaland, Manipur, and the northeastern states. One-stop centers and health on bike, like Mumbai, Manipur. Nagaland, it has come to use the massive SMS services. They have come in use. Welcome back clinics have shown very good outcome. And now we have to understand, like in Nagaland, we had this evening clinics, health on bike, and the wellness centers, and the condoms were distributed from the bikes, the ART were dispensed from the bikes. We had these evening clinics so that the ART patients did not miss their daily wage and their jobs and all. And in Telangana, there were the churches which were used as a site where the follow-ups could be done. And what we need to understand at the end of the total discussion is basically we need to categorize our patients. We need to use our health system at an optimal level so that I can divide my time with a tried system, so that I have to cater, I have to give more attention to my patient who needs that. So a category A patient needs more time than a category B. Again, a category C patient needs the maximum amount of time where he is failing, and this patient also needs a peer support. Have come to the end of my discussion. If anyone has any queries, they may please post in the chat box, or they can talk to me over telephone. Thank you. And thank you for your patient listening. Sweta, I'm done. Chat box. Wait. Yeah, we have a question in the chat box. It has been mentioned that a patient is having a non-communicable disease. So it's a hypertension, uncontrolled hypertension, or diabetes. Uh, if this patient is taking services from the ART center for his diabetes or hypertension, then we have no choice. We have to call this patient. But that will, irrespective of that, that patient will be in the category B, because as per our ART, looking from the ART point of view, this patient is virologically suppressed. He is taking his ART medication on time. So he does not need those ART counseling and intensified visits and phone calls. He will fall into the category B package. He can be given MMD, but the hypertensive issues and the blood sugar issues, these need to be followed up. If he is eager to follow up at a center or a primary health center or a clinic nearby his home, we can counsel that patient that you need not travel such a long distance to come to the ART center. You can go for a visit to your local physician, a local primary health center. We have all these centers everywhere almost. So these follow-ups may be done there. But if the patient is willing to come to the ART center, he can come, but that does not mean that he will be falling in any other category. He will be falling in package B itself. I think I'm clear. Same question, some NCD, then how to monitor this patient. Non-communicable diseases are basically not part of the packages. Okay. We are like the package is basically dependent on the ART adherence, ART outcome, that is suppressed or unsuppressed, and the diseases that are considered as opportunistic for ART, like the stage 3 and the stage 4. We will not consider the NCDs to be a deterring factor for him. So here the hypertension or diabetes, as I said, can well be taken off by any other physician near his home, at any primary healthcare center, at any other medicine OPDs. But if the patient insists on coming, we can't help. But in that case also, he can be given an MMD. He just drops in with a fasting blood sugar report or an HbA1c A1C report. But that patient can also bypass the counselor. He just can come to the nursing staff to show his blood sugar level, or he can measure his blood pressure at the desk of the nursing staff. So that way we can, this is basically a case-to-case basis type thing, but he will be under package B. Any other questions? I'm unable to unmute. Thank you, everyone. I'm ending my session. If you have any other queries, you can always call me, or you can email to coestm1@gmail.com. Okay, thank you.